An adult female patient presents with chronic lower back pain. I am showing you AP and lateral radiographs of the lumbar spine. Describe the findings.
Let me just study this for a second. Right. The spine radiographs demonstrate pronounced posterior vertebral scalloping affecting the lumbar vertebrae. On the lateral view, the anteroposterior spinal canal diameter is significantly narrowed with short, thick pedicles. The AP film reveals progressive caudal narrowing of the interpedicular distance from the upper to the lower lumbar spine, which is the opposite of the normal pattern. The visualized portions of the pelvic girdle show squared iliac wings. These features are highly diagnostic of achondroplasia.
What is the differential diagnosis for posterior vertebral scalloping, and how can we differentiate them on imaging?
The differential diagnosis for posterior vertebral scalloping includes intrathecal pressure effects from spinal canal tumors, syringomyelia, or communicating hydrocephalus, as well as dural ectasia in neurofibromatosis type 1, Marfan's, and Ehlers-Danlos syndromes. It is also associated with acromegaly and Morquio's syndrome. We can distinguish achondroplasia by the pathognomonic progressive caudal narrowing of the lumbar interpedicular distance. Neurofibromatosis type 1 can be differentiated by the presence of cutaneous neurofibromas and lateral thoracic meningoceles, while acromegaly is characterized by rectangular vertebral bodies and diffuse chondrocalcinosis.
I am showing you radiographs of the skull and pelvis of this patient. Describe the findings and explain their clinical significance.
The skull radiograph demonstrates macrocephaly with a prominent, bulging forehead and a J-shaped sella turcica. The pelvic radiograph shows squared iliac wings, a horizontal orientation of the sacrum, and a flattened pelvic inlet resembling a champagne glass. The narrowed foramen magnum in the skull is a critical complication that can cause cervicomedullary compression, sleep apnea, or obstructive hydrocephalus. The combination of short lumbar pedicles, narrowed interpedicular distance, and pelvic narrowing predisposes these patients to severe canal stenosis.
I'm showing you radiographs of the lower extremities and hand. Describe the findings.
The limb radiographs demonstrate symmetric, bilateral shortening of the long bones with marked metaphyseal flaring, producing a classic trumpet appearance. The hand radiograph shows short, stubby tubular bones, particularly affecting the metacarpals and phalanges, with separation between the middle and ring fingers, typical of a trident hand. These abnormalities reflect a generalized, symmetric defect in endochondral bone growth, which spares intramembranous bone formation.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior films to assess for any progressive spinal alignment changes or osteophyte formation. I would strongly recommend a lumbar spine MRI or CT myelogram to evaluate the degree of canal stenosis, cord compression, or cauda equina crowding. I would also suggest a brain MRI to assess the caliber of the foramen magnum and rule out hydrocephalus. Finally, I would document these findings and refer the patient to a spine specialist or neurosurgeon for decompression surgery if neurological deficits or claudication are present.